Okay, good evening, everyone, and welcome to our MyMedicare and Capacity webinar. My name's Deb Peluso, Project Lead GP Matching at Western Victoria PHN, and I will be your facilitator this evening. Before we kick off, I'd like to acknowledge the Wathaurong land that I'm living on and pay my respects to the elders, both past and present. We at West Vic PHN support self-determination for First Nations people and organisations. So you can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. You can see that slide has come up now, and we'll put the link to access our recorded webinar events into the chat. Thanks, Jade. Please see our upcoming events on the screen now, and you can register for our events on our website. We'll put this link into the chat for you also. We're excited to announce our annual conference has been set. So please save the date for the 2025 Primary Care Conference, which will be held at the stunning Goods Shed in Ballarat. Many of you will be familiar with Health Pathways, the free online resource with the localised clinical and referral information for health practitioners. There'll be a link in the chat and you will find pathways related to this topic available. A certificate of attendance will be emailed to participants. Please take a moment to check that your full name is displayed accurately on your screen. If not, or if you're unsure, please rename yourself or type your first and last name into the chat box now. This will ensure we can issue you with a certificate of attendance. Please keep yourself on mute unless you would like to ask a question. We encourage interactivity and discussions. Please feel free to type questions in the chat box at any time or take yourself off mute during the designated Q&A time at the end of the formal presentations. Your feedback is important to us, so please take the time to complete the event survey after the webinar. There'll be a link in the chat box to complete the survey as well. Our presenter for this evening is Wendy O'Meara from Larter Consulting, followed by a short presentation on PUFFIN from Sarah Crowe, West Vic PHN.
Thank you so much, Deb, and welcome everyone. It's great to see you all tonight. Thank you for taking the time at the end of what I'm sure has been a busy day to attend this webinar. I'd like to begin by also acknowledging the traditional custodians of the lands of which we are virtually meeting tonight and pay my respects to their elders, both past and present. I also extend that respect to any First Nations people who may be joining us tonight. So MyMedicare has been around for a little while now, and it's quite easy to become a little bit complacent with our patient registrations. We worked hard when it was first introduced, and then again when the aged care incentive started, but recently it seems to have been put a little bit on the back burner with everything else going on in GP land. So tonight we're going to talk about just a refresher on what MyMedicare is and the aged care incentive, remembering that MyMedicare registrations are linked to both that program and the future changes around chronic condition and mental health. So we need to get those registrations going. So at the end of tonight's workshop, you should be able to identify the components of the MyMedicare program, which have been introduced today. Describe the general practice in aged care incentive, including the minimum servicing requirements, and recognise the need for both practice discussion and planning to recognise the roles and responsibilities to prepare your practice for the changes, not just what we've got now, but what's coming. So what is MyMedicare? It's a voluntary patient registration model designed to strengthen the relationship between patients and their general practice team. By encouraging patients to register with their specific practice, it promotes a more consistent and coordinated approach to their healthcare, along with fostering a stronger bond between the patients and their GPs. The increased continuity of care and stronger relationships are expected to lead to improved health outcomes for our patients. It was introduced as part of the Medicare, of Strengthening Medicare Task Force, which was in December 22, with future recommendations to be rolled out over a 10-year period. Multiple incentives such as MyMedicare, the GPACE we already have, but the changes to chronic disease and mental health, which will be rolled out in July and November respectively, are also all linked to MyMedicare registrations. So the Strengthening Medicare Task Force focus, basically what have they given us, or what have we seen from as a result of the recommendations? The first one was to improve patient access to care and reduce pressure on hospitals. So in response to that, we've seen the implementation of multiple urgent care centres across Australia to help the GP practices with the overload, but also obviously the main incentive is to reduce pressure on the EDs, or the ED departments in hospitals. There's going to be additional funding allocated to allied health professionals to work alongside general practice and other healthcare providers to address a more wraparound model of care. Making primary care more affordable with the triple bulk billing incentive that will be available to all Medicare card holders as of the 1st of November. And of course, the improving of prevention and management of ongoing chronic conditions through the implementation of the new GP chronic condition management plan. What are the benefits to our patient? Obviously, the greatest is basically the continuity of care. By patients registering with us as a practice, the hope is that they will then access all their healthcare needs from the one GP or the one practice, leading to better outcomes and a greater continuity of care. Being registered for our patients gives them the benefits to the longer subsidised telehealth consultations with their GP, and of course the more regular visits to the aged care facilities through the GPACE, which we're going to cover off on tonight. Along with that, there is the introduction of the frequent hospital incentives, which there's still not a lot out there. I did try to find more information today. It was to be introduced in 2024 with 9 PHNs being involved. Basically, it's about identifying patients with chronic conditions who frequently attend emergency departments, up to 10 presentations a year, and try and engage them or direct them to a general practice who can then take on their care and help them to reduce those admissions. So that's the benefits to the patients. What about to us, the practice? So by registering for MyMedicare, basically practices can access more information about regular patients, making it easier to tailor the services to best fit our patients' needs. Again, the new longer telehealth linked to MyMedicare, giving us those patients who do require those longer phone consults access to level C and D with their usual GP, and of course the triple bulk billing incentive for those longer telehealth consultations, both C, D and E, for children under 16, pensioners and concession card holders until November, where it will be available to everyone. MyMedicare registration is also linked to the chronic condition management, which will roll out on the 1st of July 25, and the Better Access Initiative changes, which will roll out on the 1st of November 25. Registered patients can only access care from the providers they're registered with, so their usual GP or any GP at that practice. However, if patients are not registered, they can still access services from their regular GP. So it's still going to stop that opportunistic billing where a patient presents to a clinic that's not their usual service provider and walk away with a chronic condition plan or a mental health plan in place. So it's going to stop that opportunistic billing. Just a few facts that we should be aware of. Patients can withdraw registration at any time. So it is voluntary, so they can choose to withdraw at any time. They can change their choice of provider at any time. So often happens where they may be seeing one GP and for whatever reason that GP may leave, or the relationship may not be what they wanted. So they have the absolute choice to change their provider whenever they feel necessary. There is an existing relationship requirement. So the patient must have had 2 visits to the practice within a 24-month period to be eligible to be registered. However, if you are located in the MMM 6 or 7, it only requires one visit to be eligible to be registered. Patients can still access care at any service. So by registering with your practice does not limit them to accessing services elsewhere if they need to. And another thing to remember is if a provider moves to a new practice and it's located close to where the practitioner may have been previously, the patient can follow that GP without having to qualify for those 2 visits in 24 months. So the pre-existing relationship has already been established, so the patient is able to follow that GP without having to re-register, or they will have to re-register at a new practice, but not having to serve those 2 and 24-month requirements. So that's a little overview of MyMedicare, the program. Now let's look at the GPACI, or the General Practice in Aged Care Incentive. I hope I'm saying that right. It used to be GPACI, and then we got told we couldn't say that, so I tend to refer to it just as the Aged Care Incentive. So just some facts. In Australia, there are approximately 200,000 people who live within our residential aged care homes who are typically over the age of 80. At the moment, care provided to these people or to these residents of these homes is more reactive than proactive. There's not a lot of preventative care going on, and many residents experience poor continuity of care as they do not have a regular GP. In response to this, and as a result of the Royal Commission into Aged Care Quality and Safety, there was a recommendation that a new model of primary care be implemented to encourage that wraparound care for residents, the same as our patients receive in general practice. So trying to incentivise GPs to take on the care of residents in aged care homes to provide that better wraparound care. The aim of the program is to improve access to both quality proactive care for patients living in aged care homes, as I said, by incentivising GPs to not only plan coordinated care, but to regularly review these patients. Participating in the aged care incentive is voluntary, and practices and providers can opt out at any time. So we had a big rush to register our patients when it was introduced in August last year. And then everything seems to have slowed down a little bit as far as registration. So and also a patient can withdraw at any time, and this can be done either at the practice level. So you in a practice are able to go on to PROTA and withdraw the patient, or the patient or legally responsible person can do this as well. The other component of the aged care incentive is around the primary health network. So PHNs have been given funding to engage and collaborate with GPs and general practices to support that provision of care. So selected PHNs will design a locally tailored solution to address service gaps within their area and encourage GPs to take on that care. There will be a monitoring and evaluation phase to ensure that payments and supporting activities are being completed. So I'm not sure whether West Vic is part of that or not, but there is an additional support of the PHNs for that program. So August 2024, the Aged Care and General Practice and Aged Care Incentive began, and it was introduced, as I said, to support regular GP visits for people living within the aged care community. It replaces the Aged Care Access Incentive that was in place prior to that, and has been introduced as a blended funding package that aims to support regular health assessments, care plans, and regular GP visits for those 200 plus aged care residents. Practices registered for MyMedicare will be paid incentives to provide their registered patients with regular visits and care planning. What does the incentive include? Basically, there is a payment of $300 per patient per year to be paid quarterly to the GP as a SIP or a service incentive payment. And then another payment of $130 per patient per year to be paid quarterly to the practice as a PIP payment. Rural loadings will apply depending on the remoteness of your community or where you are in the M status, but the loadings that you receive on your PIP payments will be also expanded to the aged care accessing payment as well. The previous cap of $10,000 has been removed, and the funding package sits on top of the existing fee-for-service. So all Medicare items that we regularly bill for our residents in aged care remain. This is an additional payment on top of that. To be eligible to be registered in the aged care incentive, the patients must be permanently living in an aged care home, not in respite. Register with the MyMedicare program and link to an eligible practice and provider. So patients can only link when there is a practice that has already registered along with a provider. They must have the aged care incentive indicator selected on their MyMedicare profile by their practice. Wasn't that fun when we had to do that? And don't forget, patients come and go in aged care homes. So remember, when new residents are admitted, that we must be registering them as part of our admission process. So you don't want to delay the process of getting them registered. So we've basically made it part of our patient induction. So when a patient's admitted, we go to the practice and admit them to the facility, and we also take the form up. So practices have been able to register since July the 1st, 2024 through MyMedicare for the aged care incentive. Providers to be eligible to participate must be linked to an eligible practice, and the patient declares them as a responsible provider for future care. So the patient must select a GP that they would like to be their responsible provider, and that's the GP that the patient is registered under through the aged care incentive payment program. So we've talked about what it is. Now let's look at what we need to do to ensure that we are meeting the servicing requirements of this incentive. So to ensure we meet the servicing requirements and receive our payments, we must deliver 2 care planning items over a 12-month period and 2 regular visits per quarter. Each must be in a separate calendar month. So basically, each quarter we only have to provide 2 regular visits and plus or minus a care planning item. We must deliver at least 8 regular services in 12-month periods. So if you're like my practice, we go to the aged care home every week, sometimes daily. So the meeting of the 2 regular visits per quarter is really quite easy to achieve. However, the care planning items need to be structured. So we need to have a process, and we're going to talk about that shortly. Excuse me. What is care planning? What items are they talking about? CMA, or the Comprehensive Medical Assessment, which is normally done when a patient is admitted to the facility, unless they have had it done. There is arguments about the ability to do it even if they've had another one done because it's a new admission, but Medicare tend to be really difficult to get that paid. So if they're a new resident, you can argue, I don't know them, I need to complete the CMA to ensure that I have the full picture for the patient that I'm taking the care of. There must also be one of the following: either a contribution to or review of a multidisciplinary care plan, which is our item 731, which is the only item that's remained as part of our old chronic condition management, and participate in a multidisciplinary case conference, either one that the GP arranges or one that the GP participates in. So as you know, there are 2 separate item numbers, whether it's something that you as a GP or your practice has instigated versus the GP participating in a case conference that someone else has requested, or a residential medication management review, or RMMR, which is an item 903. So that is what is classed as care planning, and you only need to provide 2 of those services in a 12-month period. So if you were to do your CMA and do your medication review, or your CMA and a contribution to the care plan, which can be billed every 3 months, you will meet the care planning requirements of the incentive. When we look at the quarterly visits, only one of those must be provided by the regular or the responsible GP. A second visit can be delivered by another GP at your practice, the nurse practitioner, Aboriginal health worker, or one of your registrars. So only one of the two each quarter must be provided by the responsible GP. Practices that are located within M 4 to 7 will be able to provide 4 regular visits in a 12-month period via telehealth, introduced in recognition that some practitioners travel a long way to some facilities that are more remote. So there has been the reduction of the number of required visits face-to-face, with an option of 4 of those being by telehealth if you are located in M 4 to 7. What do regular visits include? Obviously, our standard attendance item number, so level B to E in the aged care home. Any services that are provided after hours. Remember, with aged care, after hours is from 6 p.m, not 8 p.m, as with other after-hours services. Any nurse practitioner services, if you're fortunate enough to have a nurse practitioner working at your practice, and practice nurse and Aboriginal health worker services as well. The triple bulk billing incentive does apply to all aged care item numbers. So that's been another incentive. Once when the triple bulk billing came in, it did get applied to all aged care homes, with that recognition of incentivising GPs, if they're not already participating in this program, to perhaps get on board. I did want to cover off on the payment periods, because there's a bit of confusion. There are 2 separate periods that we need to take into consideration. So the quarterly payment assessment period is set dates from 1st of July to 30th of September, and then from October, December. So that is when the assessment periods are when the periods are assessed for payment. However, provision of the 12-month care for a patient is basically broken down into different quarters. So that should actually, it's basically designed to, what I guess I want you really to know is that if a patient or resident is admitted to an aged care facility in November, you have 12 months from November to next November to meet the 12-month care period. So the health assessment and the medication review or the CMA. So they don't have to be done in the payment quarter. So the reason I say that is if you have a patient who's admitted in November and you look at the payment assessment period from October to December, a lot of practices think, oh, I've got to get all these, my first 2 lots of services done by December. No, that's not the case. So it's 2 separate reference periods that we're talking about. So I just wanted to bring that up, because a lot of GPs think that they have to have the services provided before the quarter or the current quarter ends. So knowing what we have to deliver and delivering it are 2 separate things. So we need to ensure that we plan. So we make sure that everything is coordinated so that we don't miss out on the incentives because we didn't provide the services within the required time. So when you look at this here, it's probably the simplest way. We have 4 quarters, and at each quarter, it basically breaks it down into what services you could potentially provide to meet the standards. So quarter 1, 2 regular services from the GP and a contribution of care of the residential aged care facilities care plan could be done in quarter 1. Quarter 2, you'll do the CMA and another 2 eligible services. Quarter 3, you do the medication review and 2 more services. And finally, in quarter 4, you could perhaps participate in the case conference and then provide those final 2 services. So you can see there's not a big requirement for us. It's about ensuring that those things don't lapse and we don't miss the time period that we've got. So planning is the key, is basically what I'm trying to say. There's another example of how it would look based on the service provision you require, broken down into months. So I find these really valuable if you're new to aged care, or this practice is newly engaged in aged care service provision. Just gives you an idea of what you should be planning. So even if we were to use these two reference charts, it would give you enough information to make sure that your service delivery was scheduled appropriately. Some things to know: if you fail to meet the care planning services, so you don't meet them in the required period, the responsible provider will be required to deliver at least one of those eligible services by the end of the first quarter of the next 12 months. So 12 months elapses and you have not met the servicing requirement by, perhaps you may have forgotten to do the CMA. The provider then has the first quarter of the next reference period to provide that service. So you do get a little bit of a get out of jail card. However, if the provider does not provide this by the quarter end, the practice and the provider will be ineligible for the aged care incentive for the remainder of the next 12-month care period. So as you can see, there is an issue, or there is, I'm trying to think of the words, it's not coming to me. We do get penalised if we don't do it. So being removed from the program would not be a good thing. So that's why these planning requirements or service delivery requirements are so important to be structured carefully so that we meet them. Other things to know also: if there is a change in the responsible provider at the same practice during that quarter, the rate or payment rate will be apportioned appropriately. So what does that mean? So for example, if the quarter is July to September and halfway through that period a GP leaves the practice and another GP takes on the care of that patient, then there may be that the $300 per patient will be paid proportionately, or the $125 per quarter may be paid 50-50. So GP 1 will get 50% and GP 2 will get 50%. However, if the service provider who left the practice has already provided the first two eligible services, that may result in that practitioner receiving the whole 100%, and the other practitioner getting nothing for that quarter. So keep that in mind if you have got changes within your practice, your practitioners. So we know what we have to do. How are we going to keep an eye on it? How do we know whether these services are being performed? So PRODA or HPOS allows us to request a forecast. You can go into PRODA and you can forecast where you're at with your patients that are registered and what you still need to provide to meet the assessment period. It will show you the services that you have performed that are eligible to date and whether the requirements have been met for each patient. If they're not met, it will list the services that have not been performed to meet those requirements. So it's pretty much a fail-safe way of ensuring that we know what our patients have had and what we need to have. That's a little bit hit or miss for me. I don't want to get to the last week of the quarter and find out that, hey, we haven't done the CMA yet and a big rush to get it sorted. So I prefer a planning type of method. Now, I use a simple Excel spreadsheet. I listed all my patients, all my residents, and what services are required, and I have already, for the 12-month period, booked my GPs in to attend to those. This is a couple that I found on the department's website, some ways you could potentially use if you're not Excel savvy and not confident setting up a spreadsheet. So this is a really great tool. I will provide links to these in the resources page, but this is one you could use to plan your resources. So 12-month period and then just clicking the boxes when they're done. Or this one, which is a little bit less friendly to look at, but it does meet the requirements. So again, whether the visits have been performed by the first section, whether the care planning requirements have been performed in the second section, and then the quarterly payments after that. As I said, though, a simple spreadsheet where you list all of your residents on one side, you list two visits per quarter, plus your CMA, case conference, medication review, then you can just book them in advance and know that those services are already planned, they're already in the system, and the GP won't miss out on their payments, nor will the practice. Because remember, if we don't provide the services or the GP doesn't provide the services, we also risk the practice not receiving the payment as well. There is a really simple tool for you to use which shows you how to access the forecasting. So how you would go into Proda and look at where you're at. So the radio button on MyMedicare has been updated to include the payment eligibility and the forecasting tool. It does take a little while to run. It's one of those things that you basically click it and walk away and come back 15, 20 minutes later and the data would have loaded. However, once you load or run a forecast, you will then be able to access that forecast future without having to rerun it. So really good idea. My GPs all do their own to make sure they're meeting their requirements. But as a practice manager, I also like to just tick those boxes and make sure, yes, we're all on track. We are all the services have been provided. Oops, I've got a few more residents. I need to make sure they're registered and go through that whole process. So the benefits for anyone who uses best practice is there's going to be automatic registration from July 1. Best practice are releasing their next, and I only speak best practice because that's what I use. So I apologise to anyone who's not using best practice, and I'm sure other service providers will follow suit fairly quickly. You'll be able to check eligibility for MyMedicare registrations directly from the demographic page, and you'll also be able to register patients directly from the demographic page. So there will be a link within best practice, talk to Proda, and you'll be able to check patients' registration status at the time they arrive at the practice. And you can register them as well, get them to sign a form, you can complete registration and they are signed up and ready to go, which is going to be great for that tedious task of having to go onto Proda once a month to see how many patients have registered for MyMedicare and update our practice software. So as I said, just for best practice at this stage, but I'm sure other service providers will be not far behind. So other things of importance, I guess, is solo practitioners can participate in the aged care incentive as long as they have a base. So as long as they have a practice, it's not designed for those services that are mobile. So GPs that travel around and go to aged care homes to provide services, there is no requirement for them. Patients participating in the GPAC will be exempt from pre-existing relationships. So as I said before, there is no requirement for a patient to have done those 2 eligible services prior to being admitted. If a responsible provider moves practices or a patient registers with a different practice, the 12-month care period will reset. So if you receive a new patient who goes, oh no, I've already, or perhaps a patient comes to your facility with a new GP, those 12-month care period will reset to day 1, the day you provide the first service. And a new responsible officer will need to be nominated, particularly if a GP leaves. So keep that in mind. If you are registering patients under your registrars who may be leaving your practice in the future, you will need to re-register them and the servicing requirement period will reset. I often get asked, what do we do with patients who are incapable of providing consent? You know, the patient is a non-verbal, has dementia or has cognitive decline and can't, make informed decisions. The responsible person, so a responsible person can provide consent on their behalf. And by a responsible person, I mean a next of kin, a medical power of attorney, a guardian. However, an aged care facility or a GP cannot sign on the patient's behalf. So there is no, the practice, a lot of practices are getting the GPs to sign because the patient can't. Unfortunately, there is no, that is not recognised. The unfortunate thing is for those residents that may not have a next of kin. We have one. She has no next of kin. She has no family. She only has guardianship for financial purposes. So there is no one to sign off for registration for her. So we are unable to register that patient. So now we know what we have to do. How do we make it work in our practice? How do we ensure that we meet these requirements and that we get patients registered for MyMedicare? So remember, it's not just about the aged care incentive, it's about all the other incentives that are beginning in the next few months that rely on MyMedicare registrations. So obviously the first thing is to ensure your practice is registered with MyMedicare through PRODA, because all of the new incentives that we are getting that are coming are reliant on MyMedicare registration. So I probably should clarify that patient does not need to be registered to access future chronic condition changes or mental health changes. However, if they are registered, your practice and your practitioners are the only ones who can provide that service. We need to educate our staff. We need to get our reception and nurses and doctors having those conversations with our patients. Nurses spend a lot of time with patients. They are in a perfect spot or place to encourage patients to register. But I find the most effective way is for the GP to have that discussion or recommend it to the patients. They are more likely to do something the GP recommends versus me, the practice manager, ringing or speaking to them, trying to get them to enrol. Ensure all your providers are linked to your organisation. New registrar season's coming up in August, so make sure you link those providers to your organisation straight away, particularly if you do look after aged care homes, and the registrar will be required to attend as part of that, because patients will not be able to select, or you will not be able to select a GP on their behalf if those providers are not linked. Starting the conversation with your patients can be difficult, and I find when I talk about this, I often get feedback, but how do I sell it to them? What benefits are? Well, 12 months ago, there wasn't a lot of benefits to our patients, but as you can see, things are changing in chronic condition and mental health and now becoming linked to it. So there's more opportunities for you or your practice to encourage your patients to register. But offer transparency. Say to your patients, by you registering as for us being your preferred provider, it will give us opportunity to access future funding that can or may increase the services we can provide to both you and your family. So there may not be anything that they are eligible for now, but future funding opportunities allow us to expand our services, and hopefully there'll be something that we can provide that will benefit you. So links to MyMedicare on your website is often a good way of doing that. Online booking platforms often have a link embedded in their booking system. So there's an opportunity to embed it in your whatever online booking system you use. You could send a text to patients with the link. I find simple instructions, though there are lots of resources available, but if they're too complicated, patients look at it and go, oh, it's too hard. So I think the ability for us to be able to register patients at point of contact is going to be a game changer as far as the registration process goes. But if you are going to provide handouts or step-by-step instructions to assist your patients, make sure they're simple and easy to read, or be like the IKEA instructions and you look at them and you have to turn them upside down and sideways to try and work out what they're actually talking about. Have registration forms readily available with your doctors, with your nurses, and in your waiting room. And don't forget to register your residents of aged care homes as soon as they're admitted, but also providing access to PRODA for your reception staff may also allow enrolment to be done quickly. So if your reception staff don't have that access, it might be worth giving it to them so that they can check registrations for you. Keep an eye on your patient enrolments. Obviously, we have to log into PRODA and check it all. But remember, patients will register themselves. It's not always about our registration process. So you need to make sure that you are aware of all the patients who have registered or who have self-registered. If you're not sure how to do that, basically when you're in Proda and you bring up your patient list, it will either say registered by practice or by patient. If they're registered by practice, it's something you have done, so you more than likely have already identified them in your clinical software. However, if the patient self-registered, you need to ensure that you draw down that data so that you can update your your patient's profile to reflect they are registered for MyMedicare. Question, how are you identifying? How are you identifying patients are enrolled? Are you going on to Proda and checking? What process or what things have you got in place? And as I said, best practice has major enhancements coming, and I'm pretty sure Medical Director and all those other services will not be far behind with the linking to the My Health record as well. So there has been some changes around chronic condition management, and part of the requirements for the new program is that we upload the chronic condition plan to our patients' My Health records. So having that available is also important. So you can manage, when you're looking at product, you can manage registrations, you can identify those who have self-registered. You should be checking it regularly to make sure that you're aware of all new registrations, and you make sure that if a responsible provider leaves your practice, that the patients are informed so they can then choose another provider to take their place. We shouldn't just pick one. We should say to the patient, often patients will get a text message to say, you'll need to re-register because the provider you are currently registered with has left the practice, and I've actually had that text message. So you do get notification that your current provider has left, and allows you then to contact the practice or select another patient. I'm sharing this with you because this is what we use. We basically put this up in our waiting room in A3 format. I'm happy to provide it to you in a Word document. I've shared it with a lot of practices who've found that it has helped to increase the questions or the conversation. So if you'd like a copy, I will send it through to the lovely ladies at WVPHN, and they can send it out to you if you'd like. But really great way to get the conversation started. Obviously, we will need to update this with chronic condition as of July and mental health come November. So data is your key, people. If you're looking at opportunities or how you're going to encourage patients, you need to look at your data. And the first thing you need to do is make sure your data is accurate. So archive inactive patients, identify and remove duplicate patients, clean up those free text diagnoses that your GPs are really good at. Record usual GP where possible. So a lot of the clinical softwares have a spot where you can record their usual GP, and make sure your GPs are coding correctly, because it allows you to search patients for those future incentives. Using your clinical software or things like PenCat or Polar for patients who require longer appointments, it allows you to focus on those for those longer telehealth. Again, recording usual GP, patients with chronic disease, running reports on those patients who have chronic disease and encouraging them to register, and those patients who regularly attend. I wonder if anyone's done, there is a report available in most softwares that tells you the top 100 patients, how many patients, by a number of visits. So I ran that yesterday. I was surprised that number one was a patient who's only been coming to us for 10 years, whereas we have patients who've been coming for 60 years. So I was expecting one of them to come up. So using the data to target specific cohorts, so patients with chronic conditions or patients who live in aged care facilities, and decide how you're going to contact them. Are you going to send them a letter? Are you going to SMS with a registration? Or are you going to give the list to the GPs and encourage them to have those conversations with the patients? Your admin staff can assist by reviewing the patient's appointments each day and putting a note, discuss MyMedicare, that prompt for the GP to have that discussion with the patients if they are in any of those eligible groups. These are things that we did. We generated a list for each doctor, and they determine which patients to contact, and we either sent letters or SMSs depending on how old they were and what method of contact they preferred. Encourage your GPs to have the conversations. Practice nurses are valuable in this process, so get your nurses involved when they're seeing patients. Send your practice nurse to the aged care home to register all your patients or register new patients, and make registration part of that initial enrolment in the aged care, when you're registering patients in the aged care facility. Make the information simple, readily available, and you will have no problems registering your patients. So I'm going to stop sharing now, invite Sarah to share her screen so that we can be amazed by her content.
Thank you, Wendy. Sorry, it took me a second there. Thanks so much for having me, and great presentation. I learned so much, as I always do with you. Now, for those who don't know, I know a lot of people in the room, but those who don't know me, I'm Sarah Crowe, the Digital Health Manager at WVPHN. And I want to tell you a story. So when the GPACI requirements came out last year, we looked at it. We looked at some of those spreadsheets which are really helpful for practice managers and GPs to manage the requirements. But we really wanted to look for a way to further support practice managers, receptionists, GPs, whoever was going to manage this huge change. It's a huge change, right? So straight away, we called a meeting with Outcome Health. Now, that's the lovely organisation that provides you with Polar. Polar is used in 180 clinics across Western Victoria. And we sat down with them and we started brainstorming to see what would a digital tool to help you manage this look like and feel like. We decided to commission Outcome Health to build a new report in Polar with us, specifically for GPACI. Now, before I give anything away, all of the Polar products have an Arctic animal that they're dedicated to, whether it's walrus or orca, Polar itself, there's husky. So we had to sit down and think about what Arctic animal we were going to call this after. And we've gone with the beautiful Arctic birds, puffin. And interestingly to know, puffins are known to be intelligent tool users. They travel extensively and they form long-term relationships. How fitting. So without further ado, I am going to quickly share my screen. And just so you know, this is so hot off the press. I didn't get access until this demo version until this afternoon. I think it was about 3 o'clock, Deb, when we were in a meeting together, and I got access to this. So I'm going to share my screen and give you a sneak peek of what is coming in July. So those of you familiar with Polar, you'll see it's quite familiar, and this is going to be free. It's going to be available to every clinic in Western Victoria that uses Polar. If you're not already using Polar, let us know. We'll get you set up and you'll have access to this tool when it's out. Now, what you're seeing here is a completely fake clinic with fake doctors like Indiana Jones, Morgan Freeman, and Dr. Strange. And you'll see here is a list of all the GPACI registered patients. You'll see across the top, these are the year quarters, the payment quarters that Wendy spoke about. And you'll see because patients join up at different times, their 12-month cycle will start at different times, but you can see really clearly where their quarters are. And what you're seeing when you see a star, so you've got a legend across the top here. And you can see when you see a star, that means there's a patient interaction that's happened in that quarter. So you'll see services. Now, don't interrogate the data too much in this version because it is very much fake and it is the first ever dummy demo version of this data, so it's not 100% accurate. But they really wanted to get me something I could show off to you all today. When you hover over someone, you can see a bit of detail about who the person is, what their Indigenous status is, how old they are, what vaccinations they might be overdue for, whether they've had their care planning items done in that 12-month cycle, and what services they've had and who provided them, whether it's by their assigned provider for GPACI or not. So we are so excited about this. You'll see there's a couple of little features. When you see the little dot, it means that one of those services has been provided, so it's partially complete that quarter. And when you see 2 dots, I'll see if I can find one. Excuse me. There we go. That's fully complete. They've had both their services for that quarter. Now, you might notice these little red flashing ones. I'll just hover over that because it's telling you that last year's care plan wasn't completed. So you really need to do that care planning item this quarter to make sure, as Wendy mentioned, you don't get removed. They don't get removed from the incentive program. Couple of other cool features we've got. If you look on the left, you can actually just look at what that doctor still has to do. And if I hover over them, it's actually going to highlight those patients for them. I love it, Wendy. I love seeing people's reactions. So this is really exciting. There's lots of filters I can be putting on here. So I'll just go back up the top. There's a whole lot of filters. So if I just want to look at one doctor, yay, thank you, Alison. If I just want to look at one doctor, I can do that and it will just show me that doctor's patients. So if I tick them, and it's just going to put the filter on. So I'm just looking at that one doctor's patients. I can filter by a whole lot of things. If I want to know who has I just want to look at the patients due for certain vaccinations. I want to look at the patients who haven't had any visits in the current quarter. You can put any of these filters on and it's going to filter out. So you're just looking at those patients as well, if that's what you'd prefer. There's so many filters in here. You can also cross-reference it with who's at risk of hospitalisation. I want to know those who are at urgent risk of hospitalisation. It looks at how many meds they're on, how many services they've had, how many chronic conditions they've had, and gives them a risk calculation. And so you can identify those patients. You can also identify what suburb they're in, which works really well if you've got aged care homes in different suburbs and you just want to look at that one aged care home. We can drill down by the suburb as well. As I said, this is free. It's still in development. We're finishing building it now, but we're hoping to release it to everyone in July. And there will be so much support available from us, the PHN, to come and sit down with you, figure out how to use it, how is it going to work, set it up the way that you want it to work. At the moment, you do have to go and flag those patients that are GPACI registered. So you have to go in and say, oh, this is when they registered and this is their assigned provider. But given what Wendy has just shared with us about best practice, actually having a field in best practice, during this webinar, I have emailed Outcome Health for us to explore how that could automatically happen in there. So thank you for that tip, Wendy. We'll see what we can do.
Wow, excellent. I just want to move to Westvic PHN now so I can access it.
Well, hopefully it will be available nationwide to anyone that uses Polar eventually. We get it first because we're building it currently. And that was our idea. So please reach out. I might get Jade to put the Digital Health Inbox email address in the follow-up email that comes from today. You're very welcome to get in contact with me if you want to have a play, have a chat about it, or be one of the first practices that has a go at using it. We'd love to have some people willing to test it and give a bit of feedback in the first couple months. We have had a couple of doctors look at it already, and we've had PHNs across the country have a bit of input into how this should look as well. So we're so excited. Good things to come, and it might be a bit easier than using a spreadsheet.
That is fantastic.
Thanks so much for having me.
Thanks, Sarah. And thank you, Wendy. So now is your opportunity to ask some questions of any of our presenters. So please put your questions in the chat box and I'll ask them on your behalf, or alternatively bring your mute off and I'll ask you or ask a question yourself. But I think we have a couple in there already that I saw. there was a question about what about locum GPs? And I think that's a great question because locums definitely have a role in maintaining care, especially in rural areas or during periods of leave and so on.
Yeah.
But Japassi's really focused on that continuity of care, isn't it? So regular presence is important. So, Wendy, would you be able to speak to how the locums can fit into the incentive structure?
Well, yeah, Deb, I agree. So unfortunately, locums don't really meet the profile for what they're trying to do. So the continuity of care is about that regular GP. However, if a locum is regularly returning to an area, perhaps 4 times a year, and is able to provide care, I can't see why they can't participate, but I think it goes against the underlying theme of that regular GP and that continuity of care at a practice. So if a locum doesn't have a practice base, I don't believe they're eligible to provide those or to register in a program. Because remember we talked before about GPs have to have a practice basically to work from or to where the practice payment, because there's 2 payments. So I would say no to that. I will look into it. I've never been asked that question. I've been asked about, doctors, those mobile doctors who go around to aged care, but I would still think if it would depend on the engagement of the locum and how long the locum was attending the specific aged care facilities.
Right. And another question, what about a nurse practitioner who's covering for a GP on leave to be able to receive any incentives? Does this work?
Yeah, we did talk about that. That was one of the requirements, that a definitely nurse practitioner, as long as a regular GP provides one service in a quarter, the other service can be provided by another GP, a nurse practitioner, or a practice nurse under the 10997. So, but good question.
Okay, and a few questions about the recording being available. That's
Yes.
fine. And I think there's a couple of questions for Sarah here. Just quickly see, everyone's saying it's fabulous and it's amazing. So we're very excited about that. The digital health email is there. Is it magically pulling the data from best practice or equivalent when patients are selected? And Sarah, I think you've responded something to that. So at the moment, you do need to flag the patients, but Westwick PHN staff will be available to come and work through this with you. And hopefully with Wendy's news about best practice implementation, Japassi details into patient demographics, we'll be able to magically make it happen. Another question, when doing multidisciplinary care plans, do we need to actually record a review of GPMP under EPC best practice, or can the GP just make a notation in the consult notes to say he or she is contributing to a care plan?
Okay, so there's 2 separate programs here. So the EPC visits are related to the chronic condition management, so the new 965, 967s. The review of a care plan, item 731, is specific to aged care facilities. So where a GP goes into the aged care home, looks at the facility's care plan and documents his or her part in that program. That's what a 731 is. So when you're talking about the EPC visits, that is under the other program, which is not available to residents in aged care homes.
Okay, great. Any other questions? Anybody want to take their mic off? No, turn their mic on, I should say. Okay, so I think that comes to a close now. So thank you so much, Wendy and Sarah, for participating today. If I could ask everyone to please take the time to complete the participant evaluation survey via the QR code on the screen, which Jade will put up in a moment, or the link in the chat. And yeah, again, thank you to our presenters today. We're very fortunate to have such expertise available. Thanks, everybody.